I'm going to go ahead and get started. My name is Kristen Nessensit, and I'm the Director of Community Relations and Fundraising for the Histiocytosis Association. Before I introduce your hosts for today's webinar, Endocrine Conditions in Erdheim-Chester Disease, I would like to briefly go over a few important housekeeping items. Next slide, please. Today's webinar is for informational purposes only. It is not a medical consultation. We encourage you to speak with your medical team about your specific circumstances. There will be time for questions at the end of the presentation. Due to time constraints, all questions may not be answered. However, we will follow up with additional information wherever possible. Today's webinar is being recorded, and we will provide a link to the recording as soon as possible after the webinar. So now it's my pleasure to introduce your hosts, Jessica Corcoran, the Executive Director of the Erdheim-Chester Disease Global Alliance, and Deanna Fournier, the Executive Director of the Histiocytosis Association. Thank you.
Thank you, Kristen. We are very excited to be here today to be able to offer this opportunity to you. Our organization specifically supports Erdheim-Chester Disease. But we have recently began partnering with the Histiocytosis Association to bring you educational webinars with histio-knowledgeable speakers. And we just thank you for joining us. And today we're going to cover endocrinology in these diseases, but we hope to offer you more webinars throughout the year. So please stay posted. And now I'm going to pass it over to Deanna.
Thank you, Jessie, and hi everyone. Thank you so much for joining us. The Histiocytosis Association is thrilled to be able to continue to partner with the ECD Global Alliance to offer these educational opportunities, and we're just really excited to introduce you to today's expert speaker. So we have Dr. Hannah-Shmouni, and he is the Director, Graduate Medical Education, Principal Investigator, Endocrine Genetics and Hypertension at the National Institutes of Health. And I'm going to turn the presentation over to Dr. Hannah-Shmouni and take it away. We're really excited to learn more about the topics that you have for us.
Thank you so much, everybody, and hope you can hear me and see me well. All right, so my name is Fady Hannah-Shmouni. I'm the Director of Graduate Medical Education and Principal Investigator with Endocrine Genetics and Hypertension at NICHD, NIH. The title of my talk today is Endocrine Conditions in Erdheim-Chester Disease. We've been studying Erdheim-Chester Disease for several years now and have contributed to the field with a focus on endocrine dysfunctions in this fascinating disorder that impacts multiple endocrine glands. So the objectives of my talk today is to try to provide an overview of the various endocrine dysfunctions that can affect a patient with Erdheim-Chester disease. And those endocrine dysfunctions can also be seen in other histiocytic disorders, so you could take home some of the general concepts and ideas for the other conditions impacted by these inflammatory processes. So I have nothing to disclose, and what I will try to also do is provide future directions and a screening methodology for endocrine dysfunctions in these conditions. So what is Erdheim-Chester disease? Well, it is a rare hematopoietic neoplasm of histiocytic origin, characterized by the accumulation of foamy macrophages, chronic inflammation, fibrosis, and potentially organ failure, with an elevated mortality at 3 years from diagnosis. The mean age at diagnosis is approximately 55 years, with a male predilection of 70%. It is truly a multisystemic disease whereby the diagnosis can be extremely challenging, and it does impact multiple endocrine systems and organs, causing multiple endocrinopathies and deficiencies that can impact the quality of life of the patients affected. Here is an illustration of the pathophysiological concepts of Erdheim-Chester disease. It is an activation of the MAP kinase pathway, with the most common mutation being in the BRAF V600E variant. And what ultimately happens when someone acquires this somatic mutation in either the BRAF or other genes implicated in this pathway is an inflammatory process in various organ systems that lead to a multi-systemic involvement with a varied signs and symptoms. Those impacting the endocrine system can lead to a variety of endocrine hormonal dysregulations, with the most common being bone involvement, bone pain, osteoporosis, diabetes insipidus with frequent urination and thirst, amongst others that I will mention shortly. Here's another illustration from the guidelines that were published in 2020, and I encourage everyone to refer to these guidelines. They're evidence-based. They were put together by experts in the field. And what this diagram really shows you are the arrays of signs and symptoms and radiographic manifestations of this condition. And I'll go over some of these with you. Some of the common signs and symptoms are ataxia, dysarthria, cognitive impairment, mood changes, discoloration around the eyes, otherwise known as Xanthelisma. It could also lead to protrusion of the eyes, otherwise known as exophthalmos. If the inflammatory condition impacts the hypothalamic or pituitary area, then that could lead to a condition called diabetes insipidus. Diabetes insipidus is traditionally divided into a central cause, which is a cause that impacts the pituitary or hypothalamic area, or a nephrogenic cause, which is a condition that impacts the kidneys and the way they sense the hormone called ADH, or antidiuretic hormone, otherwise referred to as vasopressin. This is a frequent comorbidity, and it can manifest with polyuria, which refers to excessive peeing, or polydipsia, which refers to excessive thirst. ECD can also impact the cardiorespiratory system and can lead to chronic cough, shortness of breath, otherwise known as dyspnea. It can impact the heart by causing bradycardia or reduced heart rate, and ultimately heart failure that could lead to shortness of breath on exertion and inability to lay flat without becoming shortness of breath, otherwise known as orthopnea. It could also lead to chronic kidney disease and renal insufficiency from obstruction of the urogenital pathway. It could also lead to decreased fertility, otherwise known as infertility, decreased testosterone level, and the medical term for lower testosterone levels are hypogonadism. It could also impact the female sex with decreased sexual desire, decreased fertility, etc. The bones are impacted by ECD. It could lead to various inflammatory processes in the bone, osteoporosis, bone pain. So it's an important comorbidity that impacts the quality of life of patients affected by ECD. All of these signs and symptoms can be more or less seen through various radiographic manifestations. However, some patients may have signs and symptoms of ECD without the sort of pathognomonic features as seen on radiographic imaging techniques. Here are some radiographic clues to the diagnosis of ECD. I want to bring to your attention figure A and F. In figure A, what you see here highlighted by the red arrow is a perinephric stranding, or you see those inflammatory processes that are surrounding the kidneys, and they could also surround the adrenal gland, which are triangular shaped structures located above the kidney. So what happens with ECD is that there is a predilection for these inflammatory cells to impact the retroperitoneal space, targeting various organs in that space, including the kidneys, the adrenal glands, and that could lead to obstruction of the kidneys, acute kidney injury, chronic kidney failure, and with or without adrenal insufficiency if the inflammatory processes extend into the adrenal glands. In figure F, you see involvement of Erdheim-Chester disease in the hypothalamic pituitary area. This is a very important endocrine system whereby most of the endocrine organs in the body are conducted by this little organ called the pituitary gland. And the pituitary gland can be referred to as the conductor of the endocrine system, and any derangement in any of the hormones secreted by the pituitary gland can lead to significant hormonal dysfunctions elsewhere in the body. So here is the pituitary gland located behind the eyes. It consists of an anterior pituitary and a posterior pituitary lobe. The pituitary gland is controlled through various hypothalamic hormones and signals. Any dysfunction of the hypothalamus, the stalk which connects the hypothalamic area to the pituitary gland, or the pituitary itself, can lead to a dysfunctional signaling through various endocrine organs as shown here. As you can see, the pituitary gland is responsible for the secretion of various hormones, including growth hormone, prolactin, LH, FSH, ACTH, TSH, ADH or vasopressin, oxytocin. And so an inflammatory process that affects the hypothalamus, infundibulum, or the pituitary gland can lead to a derangement of one or several of these pituitary hormones. If there is a single deficiency, we call it as an isolated pituitary hormone deficiency. And in the case of ECD, the most common isolated pituitary hormone deficiency is ADH or vasopressin that then leads to excessive thirst and peeing. However, individuals with ECD can also manifest with multiple endocrine hormone dysfunctions, and that is referred to as either partial or pan-hypopituitarism. For instance, if there's an inflammation affecting the stalk or the hypothalamus or the pituitary gland, that could lead to multiple hormonal deficiencies, including a deficiency in growth hormone. That could lead to excess weight gain, decreased quality of life. A deficiency in TSH that could lead to central hypothyroidism or a deficiency in thyroid hormones, and ADH deficiency or diabetes insipidus. So the message here is that every individual with ECD should be worked up for the possibility of multiple hormonal deficiencies. And that is the most important message that I want to deliver today, is that because this condition can impact so many different endocrine systems, it is prudent and important for every individual with ECD to get a thorough endocrine or hormonal evaluation that will potentially cover all of these hormones and others as the clinician sees best fit based on the signs and symptoms that are being provided by the patient. Here's an example of an important axis that regulates the body's stress response, otherwise referred to as the Hpa axis or the hypothalamic pituitary adrenal axis. Normally, the hypothalamus secretes a hormone called CRH that then tells the anterior pituitary gland to release its ACTH, that then in turn tells the adrenal glands to release cortisol. What happens if there is an infiltration or an inflammatory process that affects the hypothalamus or the anterior pituitary is that there is a reduction in the mechanism or production of ACTH and or CRH release, which will then impact cortisol production. And a deficiency of cortisol is called adrenal insufficiency. And this can lead to major problems, including increased mortality, decreased quality of life, fatigue, and other signs and symptoms. It is important for an individual with ECD to have this axis intact. This axis is often perturbated by exogenous steroid use. So if someone is on high doses of prednisone or other steroids for whatever reasons, that will then tell the hypothalamus and the pituitary glands to not release their normal hormones, and that can lead to endogenous cortisol deficiency. If someone abruptly stops glucocorticoids such as prednisone, it will take time for this cycle to wake up, and an individual can live with low cortisol for a long time without them knowing that they have a cortisol deficiency. So for those on high doses of steroids, please discuss with your medical providers the possibility of having adrenal insufficiency and how to mitigate that. For those that are not on chronic steroids, but have ECD with hypothalamic or pituitary involvement, it would be very important and essential to evaluate whether this axis is normal through specialized testing. Here's another important axis that is perturbated in patients with ECD. Again, we have the hypothalamic region sending signals to the pituitary region, with the pituitary gland being the conductor of the body's hormone orchestra. The pituitary gland in turn tells the thyroid gland through the release of TSH to release various thyroid hormones. What we know is that, again, any inflammatory processes that affect the hypothalamus or pituitary gland, including Langerhans cell histiocytosis, can impact this pathway and lead to deficiency in thyroid hormones. So there are various types of thyroid deficiencies. The primary hypothyroidism refers to a deficiency in the production of thyroid hormones from the thyroid gland. And the most common cause is Hashimoto's thyroiditis, or an autoimmune condition that leads to destruction of the thyroid gland. This is a very common condition. It can impact 4 to 5% of the population. And it may coexist in an individual with ECD. So these are the patients that have an elevated TSH, a positive thyroid peroxidase antibody, or TPO antibody, that may denote an inflammatory or an autoimmune condition independent of ECD that could lead to failure of the thyroid gland. Interestingly, interferon therapy that was used for ECD therapy can cause sort of this inflammatory condition or unmasking of Hashimoto's thyroiditis. What's more common is the subclinical hypothyroidism picture. This is defined as a TSH within the reference range with a normal free T4. This can impact a lot of patients across various age groups. And the third entity of hypothyroidism is overt hypothyroidism. These are individuals with very high TSH of over 10 and a very low free T4. And central hypothyroidism, which may be seen in patients with ECD because of the involvement of the hypothalamus or pituitary area. So what we did at the NIH is we had an active protocol called the Clinical and Pathophysiological Investigations into ECD, referred to as 11HG0207, which was a natural history study designed to better understand and describe the natural history, pathophysiology, and treatment response in individuals with ECD. This was a prospective design to enroll and follow qualified men and women of all ethnic groups from ages 2 to 80 years who were screened for candidacy prior to enrollment at the NIH Clinical Center, and with follow-up every 2 to 3 years. Now, this protocol has closed, but it gave us an opportunity to go back and analyze a lot of the endocrine hormones and investigations that were collected as part of the study. All of those 61 subjects underwent various baseline endocrine hormone testings of the pituitary gland, the thyroid, vitamin D, lipid panel or cholesterol panel, testosterone for males, and dynamic endocrine testing as indicated to confirm the endocrine hormone deficiency. What we found, interestingly, when we reviewed our records for pituitary dysfunction, is that out of the 61 patients that were investigated for pituitary dysfunctions, approximately 29 of the 61 had abnormal pituitary imaging, and this is a significant number. 32 had normal pituitary imaging. 15 of the 61 study cohorts that were evaluated were females, 7 of which had abnormal pituitary imaging. Most of our patient population had the BRAF pathogenic variant with a positivity rate of 54%. 51% of the population with the abnormal pituitary imaging had the positive BRAF variant. Interestingly, all of the individuals that we looked at with abnormal pituitary imaging had several endocrine hormone deficiencies arising from the pituitary gland, as opposed to none for those with normal pituitary imaging. And the most frequent pituitary hormonal dysregulation was indeed diabetes insipidus, which was present in 36% of the entire cohort of our ECD population, but 81% of those with abnormal pituitary imaging. We did find a number of pituitary defects in individuals with abnormal pituitary imaging, and this is labeled as panhypopituitarism. So the take-home point here is that a fair number of individuals with ECD have diabetes insipidus or more than one endocrine dysfunction arising from the pituitary gland, otherwise known as panhypopituitarism. And oftentimes these hormonal deficiencies can be seen through various abnormal signaling on pituitary imaging, with the most important imaging being the pituitary MRI. Here's a list of the pituitary imaging abnormalities that we find in our cohort of 61 subjects. The most common pituitary pituitary imaging abnormality was a thickened pituitary stalk, which was present in 24% of our cohort. Some of the pituitary glands on MRI had abnormal morphology. Some were small, which may indicate atrophy or evolution of this panhypopituitary concept arising as a result of inflammation. Some had deviation of certain pituitary morphologic markers, including deviation of the stalk. Some had pituitary encasement or involvement of the inflammatory process associated with ECD around the pituitary gland. And we found other incidental findings that we believe are not truly part of the pathophysiology of ECD, but can also be commonly present as an incidental finding on imaging, including an empty sella, a microadenoma, a pars intermediate cyst, or a Rathke's cyst. Having said that, the inflammatory milieu that arises in the sella from ECD can create various anatomic changes, including a partial or a complete empty sella. And so an empty sella can be viewed as an entity that could arise from the inflammatory milieu from ECD and should not be discounted as a potential supplemental feature of ECD on imaging, but it's not a specific sign. Here are some imaging abnormalities from our patient populations. In figure A, you could see the enlargement of the stalk from involvement of the ECD. What tends to happen here is that the connection between the hypothalamus above it and the pituitary gland below it is affected by this inflammation. So the signaling between the two important organs in this region is impacted, which will then lead to a dysfunctional release of various hormones from the pituitary gland. In figure B, you have involvement of the hypothalamus, which sits above the stalk, and the hypothalamus is the grandfather of the endocrine system, and through its connection with the pituitary gland helps regulate various hormones. Here you see a global involvement of the stalk and the pituitary gland. This is another figure with the involvement of various aspects of the sella. And finally, another, in the lower figure B, another pan involvement of ECD impacting the hypothalamus, stalk, and pituitary gland, leading to various morphological changes yet not characteristic of ECD, but in someone with a known history of ECD or a BRAF V600 mutation may certainly suggest an underlying pituitary deficiency, which should be confirmed with hormonal testing. These are other sets of abnormal pituitary imaging abnormalities with the same theme, showing an inflammatory infiltrative process impacting the anatomy of this region, which will then translate to various hormonal deficiencies. So what I just told you about was the pituitary dysfunctions that can arise from ECD. This can lead to diabetes insipidus or panhypopituitarism, defined as several hormonal abnormalities due to involvement of these activated neoplastic cells in that confined space referred to as the cella that holds the pituitary gland, stalk, and hypothalamus. We also looked at the other hormonal entity, which is hypothyroidism or low thyroid state. And we studied our ECD population, whom had a mean age of 54 years, a male percentage of 75%. The time to hypothyroidism diagnosis was about 2 years from the diagnosis of ECD. So this is sort of a delayed diagnosis that someone might have lived with for a long time and potentially preceding the diagnosis of ECD. 17 or 28% of our ECD population had some sort of hypothyroidism. And this is significant because the prevalence of hypothyroidism in the population is about 4%. So individuals with ECD are much more likely to have hypothyroidism or low thyroid hormone levels than the average individual. Interestingly, TSH as the sole hormone to indicate hypothyroidism can lead to a falsely normal value. So it is important to check a full thyroid hormone panel when someone has the potential for central hypothyroidism, and a full thyroid hormone panel entails a TSH, free T4, T3, and I would add a thyroid peroxidase antibody to ensure that the type of thyroid disease that the individual may have is not sort of the common bread and butter disease, which is the Hashimoto's thyroiditis entity, which is potentially unrelated to ECD, or a central hypothyroidism picture. And in our study population, most of our individuals had hypothyroidism of the type that arises from a pituitary or a hypothalamic dysfunction, and it can coexist with other pituitary hormonal deficiencies. So in someone with hypothyroidism and ECD, look at other pituitary hormonal deficiencies because they can coexist. Don't just get a TSH because that can miss a central hypothyroidism picture. So when putting all of this together, we published our hypothyroidism data in JAMA Open Access and laid out a screening algorithm for hypothyroidism in patients with ECD. If you're interested in knowing more about this work, you could certainly find it free access in the JAMA Open Access website. You will come across this table that will suggest an algorithm for patients with ECD with the intent of not missing the central hypothyroidism component that could be missed if the practitioner only orders a TSH. So our recommendation is to check a free T4, a T3, those are the thyroid hormones, the circulating thyroid hormones, in conjunction with the TSH and the thyroid peroxidase antibodies. And based on what you find, based on those results, you can either go in the thyroid primary hypothyroidism dysfunction algorithm or the central pituitary dysfunction algorithm, which may call for evaluation of other hormones that can coexist with hypothyroidism. So we think that there is certainly a progression of pituitary dysfunction that can occur either in isolation or together. And we propose this spectrum of pituitary imaging abnormalities that can arise as a sequence in individuals with ECD, with some having normal imaging features and others with the abnormalities that I showed you earlier that can then translate into various hormonal deficiencies, with the most common being growth hormone and hypogonadism. And at the later stages of inflammation, individuals can then develop hypothyroidism, adrenal insufficiency, with or without diabetes insipidus, that I think can also be placed earlier on this spectrum of pituitary deficiency. The ultimate cause will lead to sort of this severe end of the spectrum, which is a complete or deficiency of more than 3 pituitary hormones that will require multiple hormonal replacement therapies. So far I spoke to you about the pituitary and the hypothalamic areas that can be impacted by ECD and can lead to either an isolated or multiple deficiencies of hormone, isolated being diabetes insipidus or hypogonadism, and the multiple being, you know, an array of various endocrine deficiencies, including hypothyroidism, diabetes insipidus, adrenal insufficiency, etc. I also walked you through our data for hypothyroidism, with the most common etiology of hypothyroidism and ECD being central hypothyroidism, that impacting the signaling from the pituitary gland to the thyroid. And here is another important comorbidity to address, which is adrenal insufficiency. And we looked at our data and we found that most of our patients don't have don't meet the biochemical criteria of adrenal insufficiency at the time they were enrolled at the NIH. But there's a fair number of individuals that had abnormal infiltration of the adrenal glands, as evidenced by the CT scan abnormalities that I showed you earlier surrounding the kidneys and the adrenal glands. But that does not necessarily translate to a biochemical deficiency. In other words, if someone has an inflammatory process surrounding the kidneys, the adrenal glands, or even the pituitary or the hypothalamus, that doesn't mean per se that they're going to get hormonal deficiency. It just means that there is an inflammatory milieu surrounding those organs, and it might evolve to a deficiency over time. And that's why it's important to establish a baseline of hormonal testing and to follow these with serial testing, maybe on a yearly basis, particularly in those with evidence of an inflammation around these important organs, to ensure that you catch the endocrine dysfunction early on that spectrum that I showed you. So the way to look at hormonal deficiencies in ECD is that it's an evolutionary spectrum that could be silent or severe, and the individual should be closely surveilled over time, perhaps in their lifetime, on a yearly basis, to ensure that if it's not present at diagnosis, that we catch it early. And it's important to catch adrenal insufficiency early because it could lead to severe manifestations, signs and symptoms, and increased mortality if unaddressed. Here's an example of an individual with adrenal insufficiency and biochemically proven low cortisol levels that have inflammation around their kidneys and adrenal glands. And that inflammation led to infiltration and destruction of the adrenal glands and decreased efficiency and production of cortisol that should be supplemented with glucocorticoids such as hydrocortisone or prednisone. Again, we looked at our data entailing 61 adult subjects with ECD with an average age of 54 and with 75% being males, most having an elevated body mass index, and those had mostly the BRAF V600E mutation. The adrenal involvement on imaging was present in about 31.6% of our patient population. 15.8 or so had pituitary stalk involvement, and about 10% of our patient population had both adrenal and pituitary stalk involvement on imaging. No one had presented with adrenal crisis, and none of our patients required mineralocorticoid replacements, but some did require glucocorticoid replacements. And we did some statistical analysis to see if we can find some associations and correlations between different parameters that may increase the risk of adrenal insufficiency. And one of the most interesting findings is that the higher the C-reactive protein levels were, and these are sort of biochemical markers of inflammation, the higher the odds of adrenal insufficiency on imaging, or rather adrenal infiltration on imaging, but not adrenal insufficiency biochemically per se. So there is a relationship between the degree of inflammation and the degree of endocrine involvement, at least on imaging, but that does not necessarily translate to a biochemical deficiency per se. An important reminder for everyone with a confirmed diagnosis of adrenal insufficiency is to wear a medical alert bracelet, and this is true for anyone with adrenal insufficiency, irrespective of the cause, including Langerhans cell histiocytosis, ECD, or other causes of adrenal insufficiency. It's important for this individual as well to carry an emergency kit, which entails a hydrocortisone injection kit into the muscle in case the individual is unable to take extra oral doses of glucocorticoids. And I encourage everybody with adrenal insufficiency to get supplies of each and to educate their caregivers and their network of family and friends about this diagnosis so they could serve you at times of emergency if needed. The other entity that we looked at was male hypogonadism, and we're still analyzing this data, but what we know is that ECD can cause inflammation in the testes or the gonads, and that could lead to a severe impairment of the production of testosterone in males, the production of sperm in males. And here is an illustration of an inflammatory process impacting a male with testicular involvement. So this is the bladder in dark, and right below the bladder are the testes. And what you see in this individual is an enlarged inflammatory process affecting the gonads that led to impaired sperm and testosterone counts. What's important to know for a male with ECD, with or without testicular involvement, is that their sperm production efficiency might be impacted. And this might be an opportunity to discuss sperm preservation opportunities and techniques with fertility doctors, particularly if the individual is interested in seeking and or is in the process of family planning. And I highly encourage individuals to seek this important opportunity to discuss these comorbidities with a fertility doctor as soon as a diagnosis of ECD is made. There are so many other endocrinopathies that can impact an individual with ECD, and I'll spend a few minutes talking about each here. Vitamin D deficiency is a very common comorbidity in the population. Every individual with ECD should be checked for vitamin D deficiency because replenishing vitamin D stores can certainly help with a lot of the signs and symptoms that are non-specific and may be shared between vitamin D deficiency and ECD. A target of vitamin D level is over 30. Try to get the level measured at least yearly. Aim for an optimal dose, or rather aim for an optimal level of vitamin D. And if the level is suboptimal, then do seek replacement therapy, which is readily available everywhere. Osteoporosis is an important comorbidity that can impact patients with ECD. It is typically diagnosed with a DEXA scan or a bone scan. I think individuals with ECD should get a DEXA scan at time of diagnosis. And then if they have a confirmed diagnosis of osteoporosis, then to seek endocrine consultation for targeted therapies. It's also important for an individual with ECD to know that the muscles that surround the bones impacted by osteoporosis should be strengthened. So having a regular exercise, which you could today find on YouTube. If you just YouTube osteoporosis related exercises, the search engine will take you through various options that will help with strengthening your core muscles that will play an important role in the eventual prognosis of osteoporosis. Do take your calcium and vitamin D for osteoporosis management as well. And make sure that you follow up any abnormality on DEXA scan with repeat DEXA scans over time. And I think your local providers or endocrinologists can help with that. High cholesterol, again, an important common comorbidity in the general population, which can also impact our patients with ECD. Make sure that your LDL, which is the bad cholesterol, is at target. Discuss statin therapy, such as rosuvastatin or atorvastatin, with your local providers if they feel that you clinically meet the threshold for getting a statin therapy, and that will help lower overall cardiovascular risk. As I showed you earlier, obesity is an important comorbidity in the general population, but also in individuals with ECD. If your BMI is elevated, please make sure to discuss various therapeutic options with your local providers. There are today a lot of medical therapies that are very, very effective at lowering someone's weight by over 10 and sometimes 20%. And these are injectables referred to as GLP-1 receptor agonist. We have a lot of safety data on their use, and they could lead to significant weight reduction. And they're also used for the treatment of diabetes. So if someone has coexisting diabetes and obesity, I think these medications should be prioritized to help address both comorbidities. But please don't discount obesity as an important cardiovascular risk factor, which can lead to cardiometabolic disease, and patients with ECD are at heightened risk for cardio and cerebrovascular events. Those with low testosterone levels can lead to gynecomastia or enlargement of the breast. Hypertension is an important comorbidity to address as well, and it could also arise from obstructive sleep apnea or snoring at night. This is another common comorbidity that is not specific to patients with ECD. And of course, diabetes, which is a common comorbidity in the general population, but it could also impact our patient population with ECD because of the aforementioned comorbidities or some of the medications used for the treatment of ECD, including steroids. Another important comorbidity that I addressed is infertility. So do talk to your local providers about infertility workup and therapy, including family planning, sperm preservation. I think this should be discussed early on. The most important message I want to give you here is that if you, as an individual with any of the histiocytic disorders, can reduce your weight, control your blood pressure, control your cholesterol with a statin or whatever therapies, control your diabetes, have an optimal A1C, exercise, eat healthy. If you address these 6 comorbidities, you could lower your cardiovascular disease by 80%. 80%, folks. This is independent of your ECD therapy or diagnosis. Everybody should strive to live a healthy life with an optimal blood pressure and an optimal BMI. That strategy alone can significantly lower the impact of those comorbidities on your overall elevated cerebrovascular risks. Here is an example of a sign that can be seen in individuals with high cholesterol. It's called Xanthelisma, but it's one of the signs that could also be present in individuals with ECD, and it might be one of the early signs that may drive an individual to seek medical attention. There are various endocrine evaluations that the guidelines that were published in 2020 proposed, and I think every individual at time of diagnosis or as they are receiving a workup for ECD should get the thorough radiographic evaluations that will also entail imaging of the pituitary gland and hypothalamic area through magnetic resonance imaging of the sella turcica, to get a testicular ultrasound for males to ensure that there is no overt involvement, which will then lead to discussions with fertility doctors about the potential for sperm preservation. And everyone with ECD, with no exception, should get evaluation for diabetes insipidus, the full pituitary panel, including a morning cortisol and ACTH, to ensure that they don't have cortisol deficiency, to ensure that they don't have hypogonadism or low testosterone or low estrogen for females, to ensure that they have a normal thyroid axis with a full thyroid panel, and the prolactin and IGF-1 are additional hormonal tests that are part of the pituitary panel to ensure that the individual doesn't have just one, but rather multiple endocrine deficiencies, which would help prioritize endocrine evaluations and treatments. There are a lot of unknowns in the histiocytic disorders. I think that as our literature and understanding evolves over endocrine dysfunctions, we will need together as multi-centers and regions all over the world to see if we share the same data, the same experience, and whether there are ethnic or sex-related differences in endocrine dysfunctions. I'm particularly interested in evaluating endocrinopathies in females impacted by ECD, and we're currently analyzing our data. But I would welcome any opportunity to partner with my colleagues on bringing more light into this important comorbidity in the female populations. And we also have an opportunity to study medication-induced endocrine dysfunctions and see if we could lower cardiovascular disease and risk down the road through addressing the various comorbidities that I mentioned, including obesity and diabetes. So in summary, ECD and histiocytic disorders in general can impact many endocrine systems, leading to various endocrinopathies. I think it's prudent, important, essential for anyone with ECD and any hint of an endocrine abnormality to see an endocrinologist that can then help trigger the series of endocrine testing, including confirmation of these endocrine dysfunctions through various endocrine dynamic testing that may not be accessible to other physicians. Infiltrative processes impacting the pituitary or hypothalamic area are common, and they could lead to severe multi-hormonal deficiencies. Every patient with ECD should be evaluated for adrenal insufficiency, hypothyroidism, the sort of pan-hypopituitary picture, regardless of their mutation status, whether it's BRAF or the other mutations along that pathway, because hormonal deficiencies can certainly impact the hormonal system at very high rates. Male hypogonadism or male testosterone deficiency is common. Screen, treat for it, because it could certainly improve someone's quality of life. And do seek early referrals to fertility clinics and doctors, particularly if there's any hint of an inflammatory process in the testes. Individuals with ECD have increased general comorbidities, including hypertension, vitamin D deficiency, diabetes, obesity. Please do not discount these comorbidities. These comorbidities lead to cardiovascular disease and death down the road in the general population. If you could help reduce them, you will help lower or even eliminate cardiovascular risk down the road. And overall, there's generally a poor biochemical and radiographic concordance in ECD, in that you may see abnormalities in the pituitary, thyroid, or adrenal gland on imaging, but that does not necessarily translate to a biochemical abnormality at that point in time. And I think that should be followed serially, preferably through endocrine care, so to ensure that the individual that will not evolve into overt disease over time. And if they do, then their hormones are replaced adequately. I would refer you to the Hormone Health Network by the Endocrine Society for any questions pertaining to general hormone nomenclature, general hormone questions or answers. They have a free app that can guide you through the various hormones that, and endocrine dysfunctions that I walked you through today in a very patient and user-friendly manner. There are other websites of possible interest: Mayo Clinic, Endocrine Society, and also please feel free to email me with any questions pertaining to any general endocrine or endocrinopathy, particularly if they arise from ECD. We also have a general endocrine clinic and program at the NIH, and happy to provide virtual consultations for those in need, independent of their comorbidity. So just please email me your interest, and we certainly move forward with that. And lastly, this was all not possible without the help of our ECD patients, community support groups, the ECD Global Alliance, the Histiocytosis Association, and of course the NIH, for providing platform for research and funding into this fascinating disease. And with that, I conclude by wishing you all well, and I'm happy to answer any questions or concerns that you may have. Thank you.
Thank you very much. That was excellent, Dr. Shmouni. We actually have a couple of questions. We have one in the Q&A section. If you'd like to read that out and help us with that.
Sure. What is it about ECD that can lead to high cholesterol related to pituitary dysfunctions? Yes, so great question. A lot of endocrine conditions can lead to high or dysfunctional cholesterol panels. For example, hypothyroidism can lead to an abnormality on the cholesterol panel. Panhypopituitarism can lead to that as well. Also, the inflammatory process might elevate cardiovascular risk, lead to endothelial dysfunction, hypertension, etc. So it's a comorbidity that can coexist, independent of whether there's a direct relationship between ECD or the treatments of ECD and high cholesterol. Overall, achieving an LDL at target based on someone's risk factors and the sort of calculated risk factors can help reduce the overall cardiovascular risk. So it's one of several entities that could be mitigated to lower an individual's cardiovascular risk. So the second question is, what type of treatment exists for men with ECD testicular involvement with low production of semen? I have more symptoms in the sexual department. Is there anything that can be done? Yes, thanks for the question. If you have confirmed low testosterone levels, I think it's important to address that with your local providers. Hypogonadism or low testosterone can lead to decreased quality of life, increased weight, and other signs and symptoms. Interestingly, testosterone administration exogenously can impact sperm count. So you want to make sure that you get a sperm analysis at baseline. Seek help from the fertility doctor if the desire is for family planning and future fertility. And then take testosterone to achieve normal values as detailed in the hypogonadism guidelines. If the issue does not correct with testosterone replacement, and if the issue is related to erectile dysfunction per se, you may want to use some enhancers such as Cialis or Viagra or other medications alike. That may certainly help enhance the overall sexual department that you're referring to. The last option would be to, again, address the other comorbidities: obesity, diabetes, live a healthy lifestyle, eat healthy, exercise. All that can impact your sexual desire and sexual function. And if none of those approaches work, then you can get referral to not only a fertility doctor, but a doctor specializing in hypogonadism that can provide other important therapeutic opportunities to mitigate those. In terms of the pathophysiology of sperm dysfunction in ECD, it's the inflammatory inflammation infiltration milieu that occurs in other organs that leads to decreased vascularity, blood supply into cells that produce semen and testosterone, and that entanglement can ultimately lead to low sperm count and testosterone, which is primarily produced in men by the testes.
Great. We had a question pop up in the chat. Is there a connection between edema and endocrine dysfunctions?
Yes, great question. Unaddressed hypothyroidism, so unaddressed severe hypothyroidism, can certainly lead to water retention, and that could lead to periorbital edema or swelling around the eyes. It could certainly lead to water retention in different parts of the body. However, the lower extremity edema can also arise from fibrosis and infiltration of the retroperitoneal area. So do not discount edema as a benign symptom, because it might arise from other important entity related to the vasculature that may be impacted by ECD. But the short answer to your question is edema can be a sign or a symptom of individuals with endocrine dysfunction, primarily hypothyroidism.
Great. We'll take this one last question, and then we'll just go ahead and wrap it up. And if anyone else has additional questions, we'll just send them through email. And we do have a contact slide that we're going to show in just a second.
That's great. Yeah, and there's one last question that came, and I think it's an important question to address. So hypogonadism is defined biochemically by having two low testosterone measurements measured in the morning. And folks, this is very, very crucial. For men, testing for testosterone, it's important to do it in the morning, preferably before 10 a.m. Don't delay measurement of testosterone to the afternoon, because physiologically, testosterone is low in the afternoon. So you might be falsely diagnosed with hypogonadism based on a low afternoon value. So make sure that you check your testosterone in the morning, and you need 2 blood samples to confirm a low testosterone based on the age-appropriate range, and your physician can guide you there. So yes, you do need a low testosterone level to define hypogonadism, because hypogonadism is a biochemical diagnosis. Thank you.
Great. If we can switch to the next slide, we'll go ahead and wrap up.
All right.
So we have ECD resources listed on this slide, and you will get a copy of this in the recording. And most of you know how to find the website. All of this information is what we have on our website and more. So, and if you can't find anything, you can always contact us. On the next slide, we have Deanna has listed the resources with the Histiocytosis Association. Again, you can contact their organization for any questions you have for LCH or any other condition that's related to histio. And one more slide. So this is our email information. Dr. Shmouni has offered his email address. If anyone has a question today that they did not want to ask online, or you just didn't have time, please do so, and he'll get back to you as soon as he can. Same with us. If you need something from one of our patient organizations, we're always happy to help. That's what we're here for. And so what's next? I think we are just going to wrap it up. So you'll be getting an email with the email recording, the webinar recording. And I also put a chat link for you guys. That's an actual brochure that Dr. Shmouni helped us create for endocrinology in ECD. So be sure to check that out, but we'll go ahead and put it in your emails as well. And anything else that we're missing, just please reach out. Thank you very much for joining us today.
Thanks, everybody.
Thank you.
Thank you very much.